Hi everyone, I'm John Barratt. I'm a kidney doctor here in Leicester and have been interested in IgA nephropathy for at least the last 25 years. As Rasheen has said, this is all about you guys today. So you need to take every opportunity to find out as much as you want about IgA nephropathy. So you need to grill us during the coffee, during lunch, whenever you have an opportunity. You should not leave Leicester without having had as many of the questions you have about IgA nephropathy answered. So as I say, I'm a nephrologist. Now what I can't do is give you specific information or advice about how you as an individual should be treated today. I'm very happy to have conversations afterwards, but you'll all be looked after by a kidney doctor in your local area. But I do get contacted a lot, and I'm happy to chat about things. But on a, certainly when we're in a conversation in a group, I would prefer not to be asked specific questions about your specific case. We can talk about general things. I'm not the only nephrologist in the room. So Chike, do you want to stand up? So Chike is my colleague. He runs the glomerular disease clinic with me. So Chike is another person to ask. And Harish, do you want to stand up? Harish is a nephrology trainee. He is another medic who is happy, I'm sure, to chat to you about general things about IgA nephropathy. But the absolute thing, you should not leave Leicester without having had as many of the questions you've got answered. Okay? So what I'm going to do is give you kind of like a basic guide to IgA nephropathy. It's going to be a bit didactic, but to be quite honest, if you have any questions and you're brave enough, just put your hand up and interrupt me, and that's absolutely fine. Okay, there'll be time for questions at the end, but if you do want to ask anything in particular, then please just interrupt me. Oh, well, there you go, that's a good start, isn't it? Okay, so you may have seen, because the first thing, hands up, when you were told you had a diagnosis, how many of you went home and went straight on the computer and Googled what on earth the doctor had just told you, if you could spell it? Yeah? Okay. So you may have picked up Berger's disease or Berger's disease. And that's what this disease used to be called. And it was called that because the first person to describe IgA nephropathy was this French pathologist in 1968. And he quite liked his name being associated with the disease. But in modern medicine, we try and get away from people's names being associated with disease because it doesn't help. You would have no idea if you looked up Berger's disease, whether it was a kidney disease, a gut disease. So IgA nephropathy kind of starts telling you something to do with kidneys. But that's where you might hear it. So the disease was first described in 1968, so just over 55 years ago. But it's been around for a lot longer. Let's make sure I've got this right around. So these are the two oldest cases I can find. And so the oldest cases are from the 18th century, but it's been around for longer than that. But these are the two oldest cases. Does anyone happen to know who John Paul Jones is? There's a KV somewhere. So this is the father of the US Navy. So he's a very famous American, although when I go to America and give talks, there's not many people in America who know who he is either. He famously took the US Navy to try and invade England. Wasn't successful, but he did try. But it's been around since at least the 18th century. It is the commonest pattern of a disease which we call a glomerulonephritis in the world. I'll explain what that means in a minute. It's the commonest pattern, but it is a rare disease. So most of the time when I would do these events, most people in the room have never met another person with IgA nephropathy. And actually, that's probably one of the most valuable things about today, is you get to meet other people. How many times you sat in a kidney outpatient waiting room looking around and thinking, and nobody says, oh, I've got this or I've got that. Nobody really talks about this condition. Nobody knows about it, and the likelihood is you're not going to come across someone. Whereas you'll all know someone who potentially has diabetes or asthma, or potentially someone who might have had a heart attack. But this disease, people don't really know about it. It is rare. If you were, say, thinking about your GP, GPs have a list somewhere between 10 and 20,000 patients. How many patients do you think in their practice in their career will they look after with IgA nephropathy? Anyone?
Less than 5.
One. So your GP is not going to have any idea about this. It was probably taught for 5 minutes at medical school. That's about it. How many people do you think your general kidney doctor, not a person who does a specialised clinic for this type of disease, how many patients do you think your general kidney doctor will be looking after every year with this condition? 10 at most. Okay? So this is a rare disease, even for people who are kidney doctors. So a lot of people get a bit fed up when they see that and they say, well, I don't really know because I don't really see this that often. And that's not just a UK thing. That happens in Europe, that happens particularly in the United States. So, this is a common issue with rare diseases. So it's not an excuse, it's just an explanation for why when you go looking for information, often it's a bit challenging to find it from the people that you see day to day. The other condition that often gets confused with IgA nephropathy is this condition called IgA vasculitis or HSP. So I put on the Facebook page a picture of a typical rash you get with this condition. And a number of people on there said, oh, wait a minute, I have that rash, but I'm told I've got IgA nephropathy. And actually, the reason for that is when you look at the kidney under the microscope, the kidney looks identical in this condition as it does in IgA nephropathy. So just to be aware of this, because sometimes people use these terms interchangeably. But IgA vasculitis is a common condition in kids. So this is Dr. Henoch and Dr. Schoenlein, which is what it used to be called, Henoch Schoenlein purpura. It was actually described for the first time much earlier than that by this London physician, where he described the typical presentation, which is a young child who complains of tummy pain, blood in the urine, a rash, and often joint pains. And this is a slightly different condition that affects more than just the kidneys, but the kidneys, if you looked at them with the microscope, look identical to IgA nephropathy. And often the rash may have appeared and disappeared as a child, perhaps been there for a week or so and gone, and everyone forgets about it. But actually, the kidney disease is something that's very similar to IgA. This is the commonest inflammation of blood vessels, vasculitis in children, but again is a rare disease. So even though we're talking about these conditions being the commonest type of these conditions, they are still rare, and therefore people often find it difficult to access information. So a bit of basics about the kidneys. The kidneys, you have two of them. They are found in the small of your back. IgA nephropathy and IgA vasculitis affect both kidneys equally, even though we only biopsy one kidney. So how many people have had a kidney biopsy in the audience? How many people enjoyed having a kidney biopsy? Okay. Never caused me any problems doing a biopsy, I have to say, but I was all over around. We normally usually biopsy the left kidney, and that's just practical because the liver's in the way of the right hand side. We will biopsy the right kidney if we need to, but it's just an anatomical thing that we usually routinely biopsy the left. And that doesn't mean to say that the disease is just affecting one kidney. This disease affects both kidneys. So you can see them here, they're right up underneath the rib cage at the back. And this is what they look like. The kidneys are essentially filtration units. And each kidney contains roughly 1 million filtration units. And those filtration units are called nephrons, which is why I'm called a nephrologist. The filtration units comprise an actual filter, and that's called the glomerulus, which you see on the right-hand side. And essentially, blood is coming in there under high pressure. The fluid component of the blood is squeezed out. That produces the early urine. And then that early urine goes through these tubules, this kind of runoff from the filter, where all the chemical constituents of that early urine are altered for the body to take back in what it needs and to make sure everything it wants to get rid of is passed out in the urine. And you have essentially 1 million of these filtration units in each kidney. The problem is if you lose a filtration unit, if it's damaged, you cannot grow any new ones. So we need to work really hard to preserve as many of these filtration units as we can. So what do the kidneys do? The kidneys' main function is to get rid of everything you don't need. And most of that is generated from metabolism of what you've eaten every day. And so what it does is it gets rid of waste products, particularly potassium, phosphate and acid. It manages how much salt or water you have in you. It controls your blood pressure. And the kidneys also produce hormones that are important, vitamin D and erythropoietin. So when you think about what your nephrologist is obsessed with, when you come and see me, if your kidneys are getting worse, we will be taking particular attention to potassium, because that will accumulate if your kidneys aren't working, because you can't get rid of it. And that potassium can affect how well your heart works. So we want to be particularly clear about that. And what I'm talking about here is at levels of kidney function where we're getting down into the teens. So the GFR level. Okay, and I'll come back to that. But this is when we're getting down to your kidney function being working at between 10 and 20%. So prior to that, these really aren't that much of an issue. But if you have been to the point where the kidney function has got that low, then these are things we're going to be looking at. We're going to be looking at your potassium, we're going to be looking at the phosphate level in your blood, and we're going to be looking at the acid level, because the kidneys just aren't able to get rid of that. And if you have got your kidney function that low, then you will be seeing and spending a lot of time with our renal dietitians, because we'll want to alter your diet so that you don't take in as much potassium, phosphate or acid, and therefore your kidneys don't have to get rid of as much. We'll be obsessed with your ankles. Are your ankles swelling? Because if your ankles are swelling, you're retaining salt and water. And salt and water go wherever gravity sends it. So if you lie in bed all day, or all night, and you're flat, all the fluid goes to your tummy, and you've got nice slim ankles. You stand up, and you're around all day, all that fluid by gravity just goes down to your legs, which is why your ankles swell at the end of the day. But in the morning, when you've been asleep all night, they come back to normal. And it's purely gravity. If I stood you on your head, all the fluid just goes to your head. It's all about gravity. So we'll be obsessed with your ankles and your weight, because that tells us if you're retaining salt or water. We will be very, very interested in your blood pressure, and I'll come on to why we're interested in that. And then, in terms of hormone function, if your kidneys start getting worse, again, we're talking about kidney function getting down to the teens, then you may be prone to developing anemia, because erythropoietin is a hormone that helps your bone marrow make red blood cells and stops you from becoming anemic. So we'll be looking at that very closely. And then we'll be looking at your bone health, because vitamin D is all about your bone health. So we'll be looking at that. Now, if you've got reasonably preserved normal kidney function, I'm not going to be too concerned about any of these. But these are things for some of you where the kidney function may be getting worse, where you'd be wondering, why is the kidney doctor even looking at this? Well, that's because these are all signs of things that happen when the kidneys don't work so well. So how does the IgA affect the kidneys? Well, I've talked about these filters. You can think of these filters as sieves. Very, very, very tightly regulated sieves that keep everything that we don't want to lose in the bloodstream and stop them appearing in the urine. And when those sieves are damaged, the holes in those sieves get a little bit bigger, and we can see blood and urine appearing, blood and protein, appear in the urine. So blood we call hematuria, and if there's protein in the urine, we call it proteinuria. And so we can see both of those with a dipstick. You can't see it, usually, or we will ask you to produce a urine sample and we'll send it off to the lab so we can measure it. But those are the signs that those filters are being damaged and the holes in those filters are a bit bigger, and we're starting to see those things appear in the urine. We want to look at your blood pressure. The kidneys are very, very important to control your blood pressure. Damaged kidneys increase your blood pressure. High blood pressure damages your kidneys. And you can imagine that can be a vicious cycle that develops, that one causes the other, and it just goes round and round in a circle. So that's something that we want to be particularly clear about. And of course you could have had a blood test for some other reason, and we'll find that your kidney function isn't working properly. So in terms of the blood test, what we measure is something called creatinine. So that's what we measure. And we take that number and we do a mathematical calculation and we generate an eGFR number. And that is called your glomerular filtration rate. And as a rule of thumb, that number generally equates to the percentage function you have of your kidneys. So if you've got a GFR of 50, it's roughly 50% function. If you've got a GFR of 10, you're working at roughly 10%. So as your creatinine goes up, your GFR goes down. Okay, and so, as I say, we don't measure GFR, we calculate it from that blood creatinine level. But all of these features here don't prove you've got IgA nephropathy. The only way you can tell you've got IgA nephropathy is with a kidney biopsy. Because all of those features there that a patient might be referred to me with could be a number of different reasons that could be the cause of kidney problems. We don't have a blood or a urine test that tells us this is IgA. We need to do a kidney biopsy. So you all have had a kidney biopsy, you all had your hand up, so that's what we get in the middle, a very, very thin core of kidney tissue, usually 2 or 3 cores because we need to do lots of different tests on it, and that is looked at under the microscope by a specialised pathologist. And so this is what it looks like. So here you can see those little round balls, each of those is a filter. Okay, and you can see that that equates to that diagram up there. And then when we do the biopsy, we're essentially looking at those tubules, those parts of the filter that alter the composition of the urine. We cut end on, so we just see a circle. So that's what a kidney biopsy looks like under the microscope. And we look in great detail at each of those filters to try and work out what the diagnosis is. And one of the things we do is we stain for the presence of IgA, the IgA protein. And you can see the kidney biopsy, every single round filter is lit up here with a green stain because the IgA is fluorescing in a green colour. And that's what Jean Berger first described in 1968. And the reason he was able to do that is because we just developed a reagent that allowed us to stain the kidney biopsy. But that's what we will see at a kidney biopsy meeting, is your biopsy will look like that. All the filters will have this IgA protein stuck in it. So any disease of the filters of the kidneys is called a glomerulonephritis, or GN, if you see that term. IgA nephropathy is just one type of glomerulonephritis. So glomerulonephritis is an inflammation of the filters. So what is this IgA protein? Well, it's one of our antibodies. Everyone has it, very important. It helps us, it's in our spit, it's in our saliva, our tears, our gastrointestinal secretions. It's designed to stop bugs getting into the body. So it sits in all those secretions, and any bugs that happen to come along, it binds to and it stops them getting into. It's a really important normal antibody that we all have. In IgA nephropathy, there are subtle changes that mean that it ends up in the kidneys. I'll talk about that in a second. But patients with IgA nephropathy have a normal functioning system that is protecting them from infection. So it's not that you're at risk of increased risk of infection, but for some reason, that IgA that's great at stopping bugs getting into the body is actually getting into your kidneys by mistake. So IgA nephropathy is very variable. I'm sure if everyone was to talk about their condition, it would have a different kind of history to it, and it would have a different ways in which it's affecting the kidneys. So in some people can live a completely healthy life with IgA and never run a risk of developing kidney failure. Whereas in others, people can be on dialysis in a matter of months to years. It's very variable. It can go away completely. That's much more common in children than it is in adults. I don't see it going away in adults, but it can in children. It can stay the same for years and years. So I've got patients who will be followed up 20 years, very little change in kidney function. But it can cause slow loss of kidney function and the risk of developing kidney failure and therefore needing dialysis or a kidney transplant. But because this is a condition that predominantly affects young people, the treatment that we would like to be able to offer everyone is a kidney transplant. actually even before you need dialysis, so that you never see a dialysis machine. You go straight from having your own kidneys working to the point where they're not working as well as they should, and you have a new kidney transplant, and therefore you don't need dialysis. But if you do get a kidney, there is a risk that this condition can come back in the transplant. So you just need to be aware of that. But nearly always things happen slowly. So there's lots of time to have conversations about what's happening. There's lots of time to prepare for what might change over time. So how can we predict? Because as soon as I have a conversation with my patients and I say, this is the diagnosis, the next question is, what's going to happen to me? For me as an individual. We can talk a lot about populations of patients, but what we want to know is what's going to happen to an individual. So these are the kind of general rules. If you've just got blood in the urine, either you can see or you can't see, with no protein, the outlook is usually very good. But what we do know is the more protein there is in the urine, the more likely you are to run into problems. If we don't control your blood pressure, you're more likely to run into problems. And if we've already got evidence that your kidneys aren't working 100%, then that is also like evidence that we may well run into problems in the future. And this is what we've known in terms of general kind of big studies of 500, 1,000 patients as general rules of thumb. We were never able to apply that to an individual. We also knew that if we looked at the kidney biopsy in great detail, we could work out specific features that might indicate someone's going to do less well. And we used something called the Oxford classification, which some of you may have seen, called the MESC score. The details are not essential, but those help us grade a kidney biopsy from IgA patients. And again, this was useful for 500,000 patient studies to give a general view. But what we really wanted was a way of combining all these to help us tell individual patients what the likelihood of progression is. And so what we have is we have an ability to use all that data now at the time you've had a kidney biopsy or for 2 years after the time of the kidney biopsy to tell you as an individual what the risk of kidney failure is going to be over the next 5 to 7 years. And so there's something called the IgA Nephropathy Risk Prediction Tool. It's available for free on your phone or your computer, and if you want to have it, then just I'll show you where you can download it from, and I've got it on my phone. And essentially, you put in the data that I just talked about: your kidney function, your blood pressure, what your protein level is in the urine, what the features are of your kidney biopsy, about your age, and something about the medications you were taking at the time of the transplant, and that will tell you what your risk of a 50% loss of kidney function or kidney failure is within the next 5 years. So I do that with all my patients. I'll look at that at the time of biopsy, and that helps me have a discussion about what's likely to be happening in the future. And this has only been around for the last few years, and it's been developed so that we can actually use this and use more data and able to use it even further away from the time of the kidney biopsy. This is allowing us to give you as an individual an idea about what's going to happen to you over the near future. Of course, as time goes by and we see how you respond to the things we're going to do with regard to treatment, we can work out what's likely to happen. And what I tend to do is if we plot all your creatinine levels or your GFR levels on a graph, that it generally follows a relatively predictable fashion. And you can extrapolate out, okay, we are here, let's just draw that line and continue it and see when we're likely to hit the time when you might need dialysis or a transplant. And of course, that becomes more and more accurate. The more data you have, the more time points you have. If you've only got 2 points, it's very difficult to do, but if I've been following you for 5 years, and I've got 5 years worth of kidney function data, I can use that to have a much more reliable prediction. Who here has Patient Knows Best, or used to be Patient View? Excellent. So if you haven't got it, please see me. This is a way for you to access your own data. So you can register for free. It allows you to access the blood test results that you have in your unit. The letters, everything that I do in my renal unit for my patient, the patient can access through Patient Knows Best. It used to be called Patient View. There's been a transition over to this new platform, but you can get your blood results, Often my patients see their blood results before I do, because they automatically upload into this system. And it can plot it out for you, so you can see what all your results have looked like. It's a really useful system if you want to know. If you worry that you're going to become obsessed with this, and it's not going to be a positive thing for you, then don't do it. But it is available, and it's available for all people with kidney disease. So what's the cause? So this is a little complicated diagram. I'm just going to talk you through it. So what we think is happening in IgA is that you've got in your bloodstream these IgA molecules that are clumped together and form these big protein lumps. They're not big in conventional terms, but for what's going on in your bloodstream, they are big. And they're prone to clogging up the filters. So that's what we can measure in the laboratory. You can measure these, and you have these in your circulation, the kidneys are getting exposed to them, and they're getting clogging up of those filters. And we think the main reason you're getting these complexes together is because there's a particular type of IgA that for some reason in IgA nephropathy is present in the circulation in higher levels than in healthy people. And that IgA tends to clump together, it's very sticky, it tends to stick to other proteins in the circulation, and it forms these big protein clumps. And we think that this IgA, that's the main problem, comes from a particular part of your immune system. And it's the immune system that lines your respiratory tract, lines your gut, and lines your genitourinary system. So then what we call the mucosal immune system, where the IgA is being produced, and it should all go one way, out into the secretions, to stop those bugs getting into the body. But for some reason, a little bit of it is going backwards and coming into the bloodstream. And there is the source of the problem. Because when it comes back into the bloodstream, it's never designed to be in the bloodstream, it's designed to be in secretions, binding to bugs. In the bloodstream, it's sticky, and it's sticking together, sticking to other proteins. And that is what is depositing in your kidneys. Now, there is a genetic background to IgA nephropathy, but it is not a genetic disease. So one of the commonest questions is, will I pass it on to my kids? Well, if there is not a strong family history of kidney disease, and by strong, I mean brothers, sisters, mum, dads, uncles, aunts with a history of kidney failure, then this is not going to be an inherited disease. There are rare families where it does run in families, and it's very, very obvious. So I will take a family history when I see someone with IgA to make sure there's no obvious kind of kidney disease running in the family. 95 to 99% of the cases I see, there is no family history. And if there is no family history, then it is highly unlikely that you are going to pass anything on to your kids. But there is a talk on genetics and IgA nephropathy on the YouTube channel. Danny Gale did it when we were in London, so if you're interested, have a look at that. So there are genetic things that we can find in big, large populations, but those genetic factors that we found only explain about between 5 and 10% of why people develop IgA nephropathy. So it's a contribution, but a small contribution. So what happens when these clumps of IgA end up in the kidneys? Well, they trigger those cells in the filters to get active. They start dividing, they start producing all these inflammatory chemicals that then leads to inflammation. And we, in the laboratory, which you may see today, we can mimic each of these by growing kidney cells and exposing them to IgA and measuring the chemicals they produce in a tissue culture situation. Or we can look at them and see them then dividing and becoming active. So we can mimic a lot of what we see here in our laboratory. And we grow a number of these different kidney cells, and we expose them to the IgA that we purify from patients' blood, and we look at what happens. And it mirrors very closely what we see in the kidney biopsy. So each of those letters in brackets is the Oxford classification we see in a kidney biopsy. And we can mimic each of those in the laboratory with the kidney cells that we grow. But the end result of this is that we get inflammation and we get scar tissue forming in the kidneys. And all of this is made much worse by activation of this thing called complement, which is part of our immune system. And the reason I bring it up is because there's a massive interest in new treatments that affect particularly the complement system. Chief, I'm sure, is going to talk about that. The key thing to understand is complement is making inflammation worse in the kidneys. And the reason we want to target it is if we can switch that off, we can switch off the inflammation and save those filters. So by understanding, doing the experiments that we do in the laboratory, we're able to start teasing out which chemicals are important and which bits of the immune system are important in driving the inflammation. And actually there are lots of new drugs now, which Chike will talk about and I'll mention, that we can pick those parts off. And therefore we can stop those different aspects of the process within the kidneys and preserve and stop these filters from being lost. So this is out of date already. If I put this up 5 years ago, drugs in development, it would have been a blank screen. This is how exciting it is in IgA nephropathy. These are all drugs that are currently being evaluated in clinical trials in IgA nephropathy. And as I say, this was, I think, Harris did this figure, the review, it's already out of date. Because there are more drugs. Yeah?
Sorry, just a question. So IgA complexes clearly damage the kidney.
Yeah.
Do you find other health conditions common among IgA patients that are not that to do with the kidneys?
So no, IgA nephropathy only affects the kidneys. So that it's not associated with other kind of abnormalities in other organs. So what's the right treatment? Because after giving the diagnosis and saying what's going to happen to me, what can you do about it? So the first thing to understand is it's always useful for you guys to get into the mind of the doctor and what are they thinking, okay? So I want to treat the IgA nephropathy. So that's the things that's only happening in you guys because you've got IgA nephropathy. So I want to treat all those things that we can see in the laboratory that are specific to you. But that's not the only thing you want to treat. Because if you've got loss of filters and you've already got damage, there are other things happening in your kidneys that are the same as are happening in anyone else's kidneys who've already had kidney damage. So there are processes here we know can potentially make the kidneys deteriorate more quickly. So we've got those processes that you're just having that are peculiar to you, that have IgA, but then there are those processes that are happening in anyone with kidney disease that we need to focus on. And then we need to focus on those conditions that are driving kidney damage that may be in addition to this. So high blood pressure I've mentioned. We know being overweight increases the risk of damage to the kidneys. You may have other conditions that are associated with kidney loss. Diabetes is becoming more and more common. So when I'm looking at a patient, I'm looking, what can I do for your IgA specifically? What can I do to protect your kidneys in a general way? And what other things are going on with you that are potentially going to make that kidney function worse? And I need to think about all three. If I just focus on the left-hand side, I'm not going to do the best for your kidneys. So that's what I'm thinking about when you come into my room. I'm thinking how much is going on for each of these different things. And so what everyone should have with IgA nephropathy, from the minute that you're diagnosed, we need to be thinking about the fact that actually you've already got some damage to the filters. So what am I going to do generally that are going to help those remaining filters? Because when you lose filters, the other filters in your kidneys work harder to try and do the job of what's been lost. And when they work harder, they're more fragile and they're more likely to pick up issues. And we know that for whatever cause of kidney disease there is. So we need to think about protecting those filters that are working harder and are more fragile. And then we also need to think, well, if you've got high blood pressure, we know we need to manage that. We need to give you lifestyle advice. And we need to manage anything else that might be causing problems with the kidneys. So these are things that we suggest to all patients with IgA nephropathy because we know they help kidney health. Regular exercise. If you go onto our YouTube channel, there's some really good advice. You do not need to be a marathon runner and you do not need to be Arnold Schwarzenegger. There are some very simple things just to increase the level of exercise. Being an ideal weight. Reducing the amount of salt in your diet. Stopping smoking. Now these seem really straightforward. These are probably the hardest things in the world for people to achieve consistently. That's why Weight Watchers have been around for 50 years and make lots of money. I'm not trying to make light of this. These are hard things to do to schedule into a busy life. Yes?
They reduce your salt, what
Sorry?
When you say reducing salt in the diet.
So we've got some great talks on the YouTube channel, which is really practical advice about the number of milligrams of sodium that you should have. And that's some really useful advice there.
On the exercise thing, is there any, I know you're saying don't be Arnold Schwarzenegger, not like you could be, but you know, is there advice in terms of should you be lifting weights, should you not, should you be, you know, kind of running a lot, or is it just general keep yourself?
It's general exercise, and again, there's some good videos on the YouTube channel from exercise physiologists talking about what it is you need to do. So general advice, swimming, walking the dog, it's not about pumping weights.
But if you want to pump weights,
If you want to, within reason, because when you do that heavy exercise, your blood pressure goes very, very high, and that can in turn cause issues with the kidneys. But gentle exercise is fine, but pumping massive amounts of weight to be it's somewhere in the middle. And the most important thing, which I'm sure you will know, is to get your blood pressure under control. So hands up who has a blood pressure machine at home. Excellent. What I advise all my patients, how many times you go to see a doctor when you've had the joy of finding somewhere to park at the hospital, the joy of then finding an outpatient, the joy of sitting around and waiting and you're 45 minutes late for your appointment, and then the doctor says your blood pressure's through the roof. So I tend not to get too excited about clinic blood pressures, but what I do ask my patients is to keep a record of their blood pressure and bring it with them when they come and see me. And the way to do your blood pressure at home is you sit yourself down, put the cuff on, measure it once, stay sat down, read a book, watch some telly, nothing too exciting, check your blood pressure again in 10 minutes time, stay sat down, do nothing, check your blood pressure a third time, 10 minutes later, and then your true blood pressure is an average of your second and third readings. And everyone's blood pressure will go down from the first to the second, possibly to the third. And that's the average that I want to see. And you do not need to be obsessed with doing your blood pressure every day or 3 times a day. I usually ask my patients to do it 2 or 3 times a month, once things are controlled. Yeah.
I was told that you don't need to restrict your sodium if you have normal blood pressure. Is that?
No, so reducing your sodium will reduce your blood pressure. It will also reduce the amount of protein in the urine. So so if you have a blood pressure machine, look into whether you can get one, and 2 or 3 times a month, measure your blood pressure in the way that I've described, and have that information on your phone or in a piece of paper. And if your nephrologist doesn't ask, tell them, because they should be asking. Because that's one of the most important things we can do to protect your kidneys against future loss of kidney function. All of these things will reduce your blood pressure.
So
Yeah.
effective diet.
Yep.
Omegas.
So,
There's
There-
a lot of
yep.
stuff on the internet saying omegas quite good for your kidneys in helping with films as well, or is that just a lot of
So there have been some randomised trials of omega fatty fish oils in IgA nephropathy. There's no definitive data that they do any benefit, but there's no evidence they do harm. If you were to take the amount of fish oil that was used in the clinical trials,
it's quite high.
people would know you were coming long before you went to the room. So again, if you want, so what I say to patients is if they want to take it, absolutely fine. It's not going to do any harm to the kidneys, but I can give no guarantee it's going to make any difference to the IgA.
You're talking about in the clinical trials, then that you definitely have a high
Yeah.
percentage.
Oh, and it was very high doses. Okay, and so most patients cannot tolerate it, and most patients' partners cannot tolerate it.
Just a good balanced diet.
So, I don't stop patients taking it. Equally for vegan diets, vegetarian diets, there is no evidence, or gluten-free diets, there is absolutely no evidence that these will alter IgA nephropathy. But if the patient feels better on it, I'm not going to stop them doing it. Okay, but I can give them no guarantee it's going to improve their IgA nephropathy. The only thing I will say is if you're a big meat eater and you go vegetarian, the likelihood is you will see a change in your creatinine, and it will go down, and it will look like your kidney function has improved. But that's just a quirk of the fact that creatinine comes from protein.
I think
And if you eat less protein,
the group actually.
yeah. So it's great, you know, if you do that, everyone thinks, oh, my kidney function. It's nothing to do with that. It's to do with the fact that the way we measure kidney function is based on this chemical in the blood. And there's a great study, in fact, from a group of medical students, where they said, how can we give a blood test result of kidney failure? So they gave them a lovely steak, they gave them Hungarian goulash, they gave them another protein loaded, and then they measured their blood creatinine level after that meal, or before and after, and they worked out which meal on a blood test result would suggest that person's developing kidney failure. And it was absolutely stark in terms of the changes.
That you just said is really important because that is all over the internet of how to improve your kidney disease, is to turn vegan or vegetarian. And as patients, we're kind of desperate, right? So we try and I've done it.
Yep.
Right? And you think, oh my goodness, my creatinine's going down. It's brilliant. So it's really, really important that message.
But if people feel better, that's absolutely, you know, as long as you're having a good balanced diet, if you're a vegetarian, a vegan, or you're going to do, that's absolutely fine as far as I'm concerned. You need to be absolutely clear though, it's no evidence it's going to improve your IgA nephropathy. And any change in your blood test is nothing to do with the fact you've suddenly grown more filters. It's a quirk of the way we measure it. Just the same. So I don't know how many of you have ever had a blood test and it's looked like it's got worse, your kidney function's got worse unexplained. First thing I do is repeat it. Because a creatinine is a concentration. So that's determined by the amount of creatinine and how much water it's dissolved in. So on a really hot day, if you're dehydrated, your creatinine level is going to go up because you've lost more water, and it will look like your kidney function's got worse. It hasn't actually. It's because of a quirk of what we measure. So just be aware of that, because you're absolutely right. People are wanting, I completely understand why they want their kidney function to be better. Just go back to thinking, is that really going to alter the number of filters I've got in my kidneys? And it's not. It's a quirk of the way we measure things.
And is it generally if kidney function drops as you get older because obviously the wear and tear on the body?
So it has been said that over the age of 40, you lose 1 ml per minute of GFR per year. There's a big debate as to whether that's actually true, because we see lots of 80-year-olds who've got completely normal kidney function. So whether it's normal, or whether it's just as you get older, you accumulate other things that can cause kidney loss, but if you don't accumulate those things, your kidneys remain normal. We just don't know the answer.
Reducing your creatinine, does it reduce the pressure on the kidney?
So reducing your, so the
So
creatinine.
if you went vegan or,
Yeah.
you know,
No, there's no evidence that works, that's relevant at all. There's been a lot of work about low protein diets for generals, and the jury's out as to whether that makes any difference.
the other question I have is about gut health and, you know, an IgA, if you can reduce your inflammation in your gut and what you eat, whether it's through gluten or whatever. Has there been any research done?
There's been a study in terms of going to gluten-free in a general IgA nephropathy population, and it had no long-term effect on kidney function. So that study's been done. If you have celiac disease, then there is absolutely evidence you should go gluten-free. But 99.9% of IgA patients do not have celiac. In fact, Chike's going to talk about a study we're going to do with a probiotic, because the other thing that everyone thinks about probiotics. No evidence at the moment, but we're going to be doing a study to look exactly for that reason about gut health and whether you can alter something in gut health and it can impact on IgA. We just don't know that. Yeah?
How about with the types of protein? Like, if you're having just say lentils compared to meat, like
There's
that
no
makes
evidence
sense.
one over another is better. What I suggest for diet is the general diet of the general population, which is a 5-a-day, healthy, balanced diet. Nothing specific for IgA nephropathy other than reducing the amount of salt in the diet. That's the key thing. So, hands up who's on one of these. Hopefully everyone in the audience is on one of these. Okay, so if you have IgA nephropathy, you need to make sure your blood pressure is controlled, and the first treatment we would give would be an ACE inhibitor or an ARB, a drug that is dialpril or sartan. And even if you don't have high blood pressure, we would want you on one of these drugs because they are protecting those fragile filters that are working harder, and they reduce the amount of protein in the urine. Now, these drugs were designed to treat high blood pressure. And if you don't have high blood pressure, the obvious side effect you're going to face is your blood pressure going too low. So we start low. If you've got normal blood pressure, we gently build the dose up to the maximum that you can take. And when you start realizing you're on too much is when you perhaps feel dizzy, when you stand up, or when you don't have as much energy as you want. Now, that's a real challenge because a lot of people times we're diagnosing IgA in 20-year-olds whose blood pressure is normally around 100, 105 anyway. So we've got not that much space to give these drugs before that blood pressure effect kicks in. Yes?
Transplant patients.
Yeah.
Should they be on
Yeah.
this? Sure.
Yeah. So we would routinely be putting someone, particularly if they've got any evidence of protein in the urine, on this. Now, there are some certain situations where we wouldn't use these in transplant settings because when we plumb the new kidney in, there can be some narrowing to the blood supply to transplant kidneys. That could be a reason why we wouldn't use them. But by and large, this would be what we use in healthy people with native kidneys or people that have transplants as well. If they've got protein. No evidence on better. Yeah, so there's everyone has their own particular one. We wouldn't use them both together.
I was reading on the Facebook group, and it seems to be, I don't know how many, but some people have mentioned that they've started treatment without, a biopsy. Would you always expect somebody to have a biopsy?
Yeah, you can't make a diagnosis there, and there are other conditions that can mimic IgA nephropathy that are very, very different, and you would need to know.
What conditions are there?
So, in terms of, any inflammation of kidneys can cause blood and protein in the urine. Particularly in the younger people, we would be thinking about something, a genetic reason, where there's a genetic abnormality to the structure of the glomerulus. And that can mimic quite closely IgA. So that's where we would want to have a kidney biopsy. Because clearly, if you've got a genetic condition, the approach is going to be different to a neurological condition. You wouldn't want to be giving therapies that target the immune system, so they've got a genetic disease.
Yeah, because I'm just loading up to squad taking out a biopsy from them. And my renal team have said that even if we do a biopsy, the treatment will be the same. And I'm like, quite well, how do you know what treatment will be if you haven't done a biopsy?
Yeah, so again, we can talk about that, in terms of an individual kind of
Yeah,
situation.
no, I'm not quite busy.
Yeah, but we would always go for a kidney biopsy.
What in the very rare situation a kidney biopsy can't be done for other, like instance, a very rare blood disorder?
So then you have to go on the balance of probability, because if it's life-threatening to put a needle into the kidneys, then that outweighs the other things.
Okay.
But of course, then you would be thinking, okay, well, how much do I think there's a genetic component, and we can do a genetic test or a blood test. So we can say, do we want to exclude the other things? We can do the blood test, and then we might just have to go with the resultant diagnosis. Oops. So let's just go back. If I can. Optimise kidney care in terms of all those things I've talked about. We reduce the amount of protein in urine to preserve kidney function. So is there anything new on the horizon? Well, there are lots of new things. Anyone on one of these drugs, an SGLT2 inhibitor? Yep. Okay, so these are coming thick and fast. Lots of data on these in general kidney disease, also in IgA nephropathy. These have been shown to, they were designed to treat diabetes. Not a great diabetes drug, but the data shows they're fantastic at protecting kidney function and the cardiovascular system. So these are drugs that are being used more and more in all forms of kidney disease. The newer kid on the block are things called endothelin receptor antagonists. these are things drugs like sparsentan and atrasentan. They have only just started reporting trial results. Sparsentan is now approved in the US by the FDA and will be coming for approval in Europe. And some of the, I know there's at least one person I think in the room who's on the PROTECT trial, which is a trial of sparsentan and IgA that we ran and we've done in Leicester. So these drugs are coming. They're coming to Europe soon. And then the other drug on that bottom right is called an MRA, a mineralocorticoid receptor antagonist, which is a big mouthful. The trials are still going on to see if they benefit patients who don't have diabetes.
The ones that are out now that you said they were going to check kidney function, are they available for post-transplant?
So
Are they new?
every study in IgA excludes people with transplants. There is absolutely no reason why these drugs shouldn't work in transplantation as well. The big challenge in transplantation is the safety side of things, because we're giving these on top of usually triple immunosuppression, which you have to stop rejection. So that's the thing we need to think carefully about. But these drugs, none of these drugs affect the immune system, so they'll be fine in the setting of transplantation. The drugs we think about that target the immune system, we need to be a bit more cautious about.
And how would a consultant decide the cocktail of drugs to go on? Are all of these?
I'll come to that again, because that's going to be the real challenge going forwards. Is the question back?
Yeah, it's about dapagliflozin specifically. The NICE guidelines say that it's great for people with IgA who've got a particular level of albumin creatinine ratio. And it just says for anyone underneath that level, there's no research. And I just wondered why everyone with IgA doesn't have them, because they've got the added benefit of protecting against heart disease as well. Why is there that line drawn around the protein?
So any approval is based on the inclusion criteria for clinical trials. So to get into a trial of any of these drugs, you have to have a certain level of kidney function, GFR, you have to have a certain level of albumin, protein in the urine. So we only know they work in that setting because it's only been tested in that setting. And so that's what will give the approval, and NICE will decide how the drug can be used in the NHS, and they will go on the evidence for the data. So if they don't know it's effective because the test trial hasn't been done, they're not going to say we should use it in that situation. So that's the whole rationale for the numbers, is the numbers go back to the clinical trials and who was allowed to be entering the clinical trial. So that's why. And the take-up is variable. Some nephrologists use a lot of these drugs, others don't. And if you've got a certain level of kidney function and you're below that level, then you routinely wouldn't give you the drug. It's NICE have not approved it for the use in that situation.
But that does still mean it could be beneficial for that.
We just don't know. We don't know either way. The other thing, of course, we do is we're going to be managing if you happen to have diabetes or anything else, we're going to be managing that as well. So coming on to now, what can we do about your IgA nephropathy specifically, which we wouldn't do in other patients? Well, I want to switch off inflammation in the kidney, because we know inflammation damages filters, and at the moment all we've had is steroids. So has anyone had a course of prednisolone? Okay, some of you have. How many enjoyed having a course of prednisolone? Okay. So this is a drug we've had for years and years and years, and it's been the only drug we've had for years and years and years. So we've had no other choice. But we are having some new agents. So I like to call these Satan's Tic Tacs, because they are, well, I would never choose to have them. They have lots of side effects. You need to be told about those side effects ahead of time. The data for how useful they are in IgA is mixed. But they're the only thing we've had to target inflammation in the kidneys up until recently. Yeah.
Sorry. Is there any evidence that, because I'm on my pre-transplant,
Yep.
and I'm on steroids with it.
You're an MMF and PrEP.
Yeah.
Yeah. So again, you know, so I can't comment specifically on individual choices. I think, you know, if we have someone with progressive IgA nephropathy, nephrologists will think about what on earth can I give you to give you any chance possible that we're going to be able to slow this disease. There is no hard data for NMF and prednisolone in a Caucasian, non-Chinese population. There have been studies done, they didn't show an effect. There have been studies done in China where they did show an effect. But it is a common kind of combination of treatments we use for any of the immune-mediated kidney diseases. GK will talk about the complement inhibitors. These, I think, are going to revolutionise how we look after IgA patients because they're going to be fantastic at stopping inflammation, but they're not available yet anywhere because they're still being looked at in clinical trials. And then we want to turn off that toxic factory that's making the IgA.
You said earlier that post-transplant the disease may not return.
Yeah.
If it's linked to the formation of the IgA or the IgA in that specific person, what factors can lead to it not returning?
So you've got to remember, a lot of people will have had the disease for 30, 40 years before they develop kidney failure. And it's likely to come back at exactly that same rate. And they probably had it since they were a child, it was just never diagnosed. So if you've got IgA nephropathy, and you're in your 30s or 40s and get a kidney transplant, it may come back, but it may not see it for 30 years. We don't go looking for it unless it becomes a problem. So we need to target those cells of the immune system that produce the IgA. And we've had nothing until recently. We can use a drug called Nefecon, which is now approved and is going to go through NICE next month. Potentially we can prescribe. The data shows that it works. It targets the production of IgA in the gut, switches off that IgA that then stops it depositing in the kidneys. So that's going through NICE and hopefully will be available on the NHS coming the end of the year. And then we've got a number of other agents that are in clinical trials that GK will talk about.
Sorry, another question.
Yeah.
Earlier you shared the risk calculator.
Yeah.
Now that I think is based on people that have had this maybe in the 90s, squeezed in the 2000s maybe.
So, well, all the way up to the last 5 years.
Okay. But I guess basically they're on prednisolone.
So most of them were. So this is what happens in an untreated population. So what we don't know is what the impact of treatment will have. We can't use that calculator to work that out because we haven't validated it. So the hope is that that will be your baseline risk, but we will modify by giving you these new treatments.
So the prognosis is probably a lot better than that calculator.
That's the prognosis if we don't do anything. Yeah. What we need to work out is how much will these new treatments impact on that. Because the idea is, so the key thing is when you get diagnosed, you will have a certain level of kidney function. We are not going to expect that kidney function to go back to normal with treatment because you have lost those filtering units and you can't regrow the filtering units. What we want is to stick it at that level for us to be life. That's the perfect win for us. And that way, if it sticks at that level, that's going to be a great situation. We're not going to, we can't regrow the filters. So if you start with a kidney function of 60%, the goal is you keep your 60% for the rest of your life. You're never going to get it back up to 100%. But that's the aspiration. But we've got all these treatments here that potentially can switch off that production of that IgA. So this is what we did have. And this is what, when you guys were diagnosed, was probably available, and that was all that doctors had available to them, really, with any kind of evidence in the literature that there was any benefit. This is what we're potentially going to have. So this is the big headache when you were talking about. This is the big headache. How am I going to use those together? If all of those were available today, how am I going to choose which one of you to give which one to? And how should I use them together? Start them all at once? Should I give them in order? And that's honestly a work in progress at the moment. The great news is, though, we now have choices because we've got all of these therapies. And yes? So cyclophosphamide is reserved for those patients who have severe inflammation and a rapid loss of kidney function. So that's an unusual presentation of IgA nephropathy. And I will see that presentation once every 3 to 5 years of true, what we call rapidly progressive glomerular necrosis. And then we would treat the cyclophosphamide also. And this is where we're talking about kidney function dropping in front of your eyes in terms of deteriorating. halving the kidney function in a matter of weeks to months. So that's where I would use it. Again, other people might use it in other situations, but that's a personal decision. But the international guidelines would suggest that any time you use cyclophosphamide in that very acute, rapidly deteriorating setting.
Situation where that has that treatment. Because the different decisions have to be made based on this drug action point of that treatment is done and incurred that risk reduction, and then just set them up on the cyclophosphamide like that.
So the key thing about cyclophosphamide is the amount that's actually given in terms of the total number of milligrams, because there are risks associated with cyclophosphamide. And in terms of whether that would influence whether I'd use any of these, I don't think it would. As long as that was out of your system and you'd fully recovered in terms of all the other normal things that we'd expect to see. Cyclophosphamide hits your bone marrow very, very hard, and you would say blood count was back normal and all those other things, but it wouldn't stop me from using any of these. But what we would do is we would not want to give you repeated cycles of cyclophosphamide, because we know there's a long-term risk from that. So what we do in IgA nephropathy at the moment is we kind of go slowly, don't we? We start a treatment, we wait to see what happens, then we'll come in with another treatment, and then we'll come in with another treatment, slowly. I think we're going to completely change how we look after IgA. We're going to hit you hard from the very beginning, because we have a lot more for us to choose from. But that's something that's only going to happen when these drugs become available. But the good news is that these drugs are coming through. The clinical trial data, which Chief is going to talk about, are looking incredibly promising for all of these classes of drugs. And as was mentioned, there's no reason why they couldn't be just as effective in recurrent disease and transplantation. The only factor we need to think about is what happens when we combine these with those tablets you have to take for rejection. And that's where we just need to be a little bit more focused. And of course, what would be great is if I could look at one of you and say, okay, because of the blood tests and the genetics, I know exactly which of these drugs to choose and which ones are not going to work. And that's precision or personalised medicine. And that is going to come over the next 5 to 10 years. We will use your genetics, we will use particular features in your biopsy, blood and urine, and that will tell us which of these therapies we need to give when. We're not anywhere near that yet, but that's the kind of work we're doing in the lab, is to try and work out. Because if we took your blood, all you IgA nephropathy patients' blood, and we exposed kidney cells to each of your IgAs, it will do something slightly different. And we need to be able to understand that so we can tailor the right treatment to the right patient. But if you take anything from this, this is the most exciting period ever in the history of IgA nephropathy, with all of these new therapies coming. Yes? Yep. Yep, so, whoops, oh dear, done that. Let me just get back. So, we are not going to control this disease with one drug. We are going to need multiple approaches. And you can, I think you are likely to be on this. We've already got people in the audience who are on both of these. And I think you're likely to be on both of those and one of those, at least. And then we're going to layer in, if you've got inflammation, one of these, and then one of these. You're not going to be on them for the rest of your life, but we're going to want to get the disease under control. And I think your kidneys and your filters are going to need as much help as possible. Because looking in the room, looking at the age of people in this room, you've got 40 to 50 years worth of life left in you. And we need to keep those filters that you've got working for that length of time. And we're going to need to be able to manage all of those processes continuously. So we are going to be on combination treatments. And but you're not going to be on all of them for the rest of your life. We're going to tailor that to what's happening. Okay? Yeah.
They're all treatment, right? In terms of taking them as a preventative, is that, so these, I don't want to talk about this, but had a transplant, there's no sign of IgA yet, but are they potential as preventative from it?
So we wouldn't do it in the setting of a kidney transplant, there's no evidence, but what we are doing for patients who potentially lost a kidney already is on their second transplant, we're proactively going looking for the IgS. So that as soon as we see anything happening, even though there's no damage to the kidneys yet, we are using these therapies. So we're coming in as early as we possibly can, rather than waiting for disease to develop.
If it already knows
Yeah. So I'm conscious I've probably gone way at a time. The machine is going to go mad at me.
so many questions.
I just want to finish by introducing Sarah. Sarah's here. So Sarah is a Fulbright specialist. So it's on there, isn't it? Yeah. So Sarah has IgA Nephropathy, and she comes from the States, and she's going to be around, and I would love for people to chat to her. Her background is as a professional fundraiser in the United States, and she's very kindly been working in the United States with the IgA Nephropathy Foundation and raising money for the Leicester Research Group. And what she's here for as part of the Fulbright Scholarship is to try and understand the approach and the thoughts about fundraising in the UK. Because you understand how things work in the US, but as we know, we speak the same language, but we are completely different people, aren't we, in terms of the US and the UK. So you want to try and understand what drives people in the UK. So Sarah is going to be around. She's going to want to come and chat to you and talk to you, because she wants to understand the UK setting and so to be able to relate that to the US. So please say hello to Sarah and over lunch or coffee. And she's going to be here with us for a couple of weeks, aren't you? And you only arrived yesterday, so and it's still, what is it, 2 o'clock in the morning or 4 o'clock in the morning home time?
6 a.m.
6 a.m. Okay, so she's just waking up. So just make sure she gets a cup of coffee first. So I'm going to stop there. Please grab me at any time during the day if you want to ask questions. And Chike is here and Harry is here if you want to ask any questions as well. So thank you very much.